I'm going to talk about deformities in patients with benign bone tumors. But remember, guys, I don't do tumors. Bone tumors is not my first language. I'm a stranger here. I don't belong to this session. But remember that for ancient Egyptians, perhaps this was the first metastatic disease in ancient Egypt, 1,200 years before Christ. So how they were treating those patients? They were treating those patients with magic spells, not with real treatments. And when I see the papers talking about deformities and tumors, how they deal with deformities and tumors, it's exactly for me like they are talking about magic spells in treating these deformities. So when they talk about external fixation, lengthening nails or something, because they speak about individual reports. So you will notice in this presentation that I didn't use any reference except this reference talking about all the Egyptians. So going back to benign tumors, perhaps we talk about some of them: osteochondroma, enchondroma, fibrous dysplasia, unicameral bone cyst, and osteosteoma. The deformities due to bone tumors may be fixed or temporary. Temporary due to pain or agonizing pain. So in such a case, which we have pelvic obliquity, apparent shortening, it's due to osteosteoma and the severe pain. So it's not fixed deformity. Sometimes you have apparent deformity. It's not a real fixed deformity. When you treat the pathology, you don't have to treat the deformity. But you also have fixed deformities due to benign tumors. You can have this deformity, you can have a valgus knee, you can have this wrist deformity, you can have elbow deformity. Why do you have a deformity? Because of the pathology of the tumor. You have a fibrous dysplasia, you have Olier's disease, perhaps you have a diseased epiphysis, or iatrogenic during treatment of the problem. During curettage, you have a non-union problem. So you have to think about the natural history, the degree of the deformity, the progression of the deformity, and the recurrence of the deformity. And if you want to manage these deformities, you can treat the deformities acute, gradual, or acute and gradual, both of them at the same time. How to assess the deformity of such cases? You have to do long film. It's important. Why do you do a long film? Because sometimes you have a primary deformity and a secondary deformity. And I wonder why many people going to the orthopedic surgeon and they have a deformity due to a benign trauma, and they ask them to wait and wait and wait. And they tell them this is the wisdom of waiting. There is no wisdom in waiting. Why? Because you are going to develop a secondary deformity. And when you want to treat a primary deformity, you have to treat a secondary deformity. So if the patient waits, he's going to have more troubles. Also, the magnitude of shortening, the mechanical axis deviation, the range of motion, and functional activities. When to correct the deformity if you have a benign tumors? You have to think about the expected shortening, the progression of the deformity, the development of secondary deformities, and the complications. So you have many parameters you have to think about before deciding to treat the deformity. The first one, the expected shortening. Remember that waiting with the patient walking with shortening can give you a pelvic obliquity, as you see here. But it's not the rule, because sometimes you have severe shortening, but no pelvic obliquity. So to remember, if you wait to correct the limb length inequality, perhaps the patient will have fixed pelvic obliquity. You see this pelvic obliquity. The progression of the deformity. This 8 years old girl, and they asked her to wait and wait and wait. But remember, this is a progressive valgus deformity. And within a few years, you are going to have laxity of the medial collateral ligament. And when you have a laxity of the medial collateral ligament, the correction of the deformity is okay, the bony deformity. But the management of the ligamentous problem is quite unpredictable. When to correct the deformity? Again, remember that sometimes if you wait, you are going to have a secondary deformity, like this case of fibrous dysplasia. And you have shepherd crook deformity of the proximal femur, which had been treated before a long time ago. But again, you have another deformity in the opposite direction, valgus tibia. Usually, when you have a primary deformity in one direction, you have a secondary deformity on the opposite direction. So if you ask the patient to wait and wait, because it is very wise to wait, you are going to have another deformity, a fixed deformity, which you have to treat also. You see here the proximal femoral deformity, the varus or shepherd crook deformity, and the valgus knee deformity. When to correct the deformity? Again, the complications can decide for you. This patient with Olier's disease was scheduled to have lengthening after a couple of years. But the patient had this fracture, had a pathological fracture of this part, which was lengthened before, I think 3 years before. When we had this fracture, we decided to use this fracture as a corticotomy, as a closed corticotomy. So we did lengthening 2 years before the planned time. Why? Because we had a closed corticotomy. Why not to correct the deformity from the deformity, to correct the deformity from the site of the fracture, and use it as a corticotomy, a closed corticotomy. The best corticotomy is a closed corticotomy. I will show you later on how we are managing this case. How to treat deformities? I didn't put any reference here. Why? Because it was simplifying the matters. There was a paper talking about external fixation in treatment to treat benign deformities in benign tumors. There is nothing to do with external fixation. It's not a matter of external fixation. It's the matter of doing gradual treatment or acute treatment, rather than using an external fixation or to use an intramedullary nail. You know, the lengthening nail has solved the problem of pin track infection only, but they have all the complications of external fixation because lengthening is lengthening. So if you want to manage deformity, we have many tools. You can use guided growth with the possibility of unpredictable results because sometimes you have unhealthy epiphysis. By guided growth in children is a valid option. Acute correction and internal fixation. You can use acute correction. You can use acute correction of treatment. You can use distraction histogenesis, not the extension. I don't use the term external fixation or internal fixation. I use the term distraction histogenesis. I talk about the pathology, not the tool. Doesn't make any difference if you use external or internal. There's nothing. So you can use one of them or all of them in the same patient. And I will show you how I can manage using all these lines of treatment in the same patient. And this is an example of guided growth at all, alone in the case of multiple excystosis. We have valgus deformity on both sides, and you see the guided growth on both sides. Simple operation. You can use acute correction and internal fixation. This is the case of fibrous dysplasia. And you have a varus femur, valgus tibia. See if you do a drawing here. And this is the axis of the proximal femur and the axis of the distal femur. And we did acute osteotomy and correction of the deformity and translation to correct the mechanical axis. You see the medial translation of the proximal segment using proximal femoral plate. So you can use acute correction and internal fixation. See how we corrected the angle. Then look to the secondary deformity of the tibia. Again, if you draw the axis of the proximal tibia and the axis of the distal tibia, they are going to meet outside the bone. That means you have two cores, or you have two apices of the deformity, and you have to do two osteotomies to correct the deformity. And this is a diagram showing the proximal axis and the distal axis, and they meet outside the bone. These drawings are drawn by my assistants. I never drew a line during the management, but they are my assistants. And now we have two, you see, we draw a third line to represent the middle segment of the bone, the proximal line and third line, and we have two cores. And if you want to correct, you have to do osteotomies, and this is an example, an osteotomy here, another osteotomy here, and you do displacement of the distal segment to correct the mechanical axis. And this is an example, two osteotomies, as you see here. One just an angulation osteotomy, and another with displacement osteotomy. I look to the lateral X-ray, the sagittal plane. Then think about the equalization of the limb length. We do CT scanogram to measure the limb length so we can lengthen or shorten. So in this case, we use open reduction internal fixation. This is an acute treatment and using internal fixation. And use distraction hysterogenesis with double osteotomies to correct the secondary deformity in the tibia. So we don't have a rule. So the people in the literature, they talk about using external fixation or using, again, this is a deformity like any other deformity. An example of the gradual treatment. You have, in cases of hereditary multiple exostosis, and you have radial head dislocation, such a patient. You have deformity, limitation of motion. So the conventional treatment in such cases, neglected cases, that you have to excise the head of the radius, which can, and the results of excision of head radius in such cases is quite unpredictable and may lead to further pain and stiffness. See the deformity. What we do gradual ulnar lengthening. Then we use the olive wires to do closed reduction using olive wires, using gradual distraction 1 millimeter per day. So in such a case, we use two techniques. Close treatment of the distracted radial head, and first we did lengthening of the ulna, so we can use both of them at the same time. And you see here the same patient with the lengthening, then correction of the dislocation. See the patient before, and this is at the end. Again, hereditary multiple exostosis and dislocated radial head. In such a case, we have to remove huge segment, and we did lengthening, and again, overcorrection because the patient was very young. So we do overcorrection by about 5 millimeters. Again, radial problems, wrist problems. See in such a case, lengthening of the radius, lengthening of the ulna and correction of the deformity. This is indirect correction of the problem. And such a case, it's the same hereditary multiple exostosis, and we have to do lengthening too. And we did lengthening, but at the end we had dislocation of the radius. And we did arthrodesis of the radius with the gradual correction of the deformity. So sometimes you can have complications and you have to manage the complications. Again, you can correct the valgus deformity in the older age with TCF. The complications of treatment. You have a unicameral bone cyst which had been treated, keratogen grafting elsewhere, then ended up with non-union after 8 months and had been treated by plating and grafting again, and was presented to me after 12 months by this picture, stiff non-union. We removed the plate and we put the frame on and we did distraction. We continued the distraction till we corrected the alignment, then compression. And you see the union. Recurrence of the deformities, how to deal with the recurrence of the deformities. Sometimes, in such a patient with Olier's disease, you have progressive deformity at the 88 years and you have severe shortening. You cannot wait until the patient wait and wait and wait. We tell the patient that there's a quite possibility, or it's quite expected, that you are going to have a recurrence of the deformity and another shortening, and so you are going to need another operation. So what we did, we lengthened the femur 10 centimeter and we corrected the deformity, and we lengthened the tibia for about 5 centimeters. It was about 15 centimeter lengthening, both of them. And this was the end picture. You see, it's an excellent picture. However, with follow-up, we have progressive valgus deformity, as you see here. And again, my fellows, they all usually do measurements. I never use any measurement. You see, this is the valgus deformity. You see, they measure this line to show that there is a marginal deformity. It's clear that's the valgus deformity. Then the axis of the femur and the axis of the tibia, and you have a femoral problem, a mild tibial problem. So it's merely femoral. So we did 8 plate on the femur and the tibia, guided growth principles. The problem here, and you have to tell the patients that the results of guided growth or temporary epiphysesis is quite unpredictable. It's not like the idiopathic genovarum or genovalgum. And I will show you in such a case, in the same patient, it worked out in some physis and it didn't work out in the ankle. So with it, you see here, the guided growth principles for the lower femur and upper tibia. And it worked out for the P and removed it. Then we put it in the ankle because we noticed with the growth that we have a valgus ankle. So during the removal of this 8 plate, we put another 8 plate on the lower tibia in the ankle. See, with progression, we had quite improvement and we have normal axis almost. The valgus deformity disappeared and we added the 8 plate of the ankle. So guided growth of the ankle. However, it improved in the ankle, but didn't correct the ankle completely. And we waited for 1.5 years. Then we removed the 8 plates. You see the position after removal. We have some shortening. It's a long way. And we told the patient that we are planning lengthening after 3 years to finish the problem of limb length inequality. However, after 6 months, we have this pathological fracture at the site of this. So we decided to use the fracture site as a closed corticotomy. You know, the best corticotomy is a closed corticotomy because he kept the blood supply. So we put the patient in a frame and we corrected the deformity or the fracture or reduced the fracture post-operatively 1 millimeter per day. Then we waited for a couple of weeks. Then we start lengthening. You see the lengthening here, 6 centimeter lengthening. So the complications can decide for you. You have a plan, but you have to modify your plan according to the complications. So you can use the complication as an advantage. So on this patient, look at the bone formation in the fracture area. You see the lengthening, I think it's a 6 or 7 centimeter lengthening. So we finished the problem. Perhaps it was three or 2.5 years before the planned treatment. You see the lengthening area. With the follow-up. You see with longer follow-up, the limb length equality. The device is almost closed, so we don't need another operation. Just we did it earlier. And this is the last follow-up X-ray. You see almost, now it's closed physis. There is no expectant shortening. And you see the patient. Correction of the deformity in spite of the complications which happen. In conclusion, management of deformities in patients with benign bone deformities can be acute, gradual, or both. Timing of treatment depends upon the degree of the deformity progression and the possibility of recurrence. The methods of treatment can be acute correction, internal fixation, guided growth, external fixation, distraction, hesitation, or any combination. You see the combinations. You can use 8-plate, external fixation at the same time. You can use internal fixation, acute treatment, external fixation, gradual treatment, all at the same time in the same patients. I think now you know why I didn't use any reference. Because what actually I do is a bit different from most of the papers talking about correction of deformities in benign tumors. Most of the papers talking are occasional papers, talking about 1, 2, or 3 patients. And they don't talk about globally about the topic. That's it. Thank you.
Thank you so much, our beloved Professor Gamal Hosny, for this very interesting and marvelous talk. We are waiting for any questions to Professor Gamal. I have a question, sir, please.
Yes, please.
From your very long experience, Professor Gamal, what's the main deciding factor in the choosing between different methods of correction?
It depends upon the situation. I don't prefer any line of treatment. Usually I modify the treatment according to the patient needs.
Yeah.
That means, you know, that you have to, sometimes you have to use all the methods in one patient, all the types of treatment in one patient. What amazes me, that the people usually are very dogmatic. They talk about external fixation or lengthening nails or guided growth or something, and they keep it as it is the line of treatment. It's not the line of treatment. It depends upon the patients. It depends upon your training. It's another point. But actually, the problems are the same. The complications are the same. And you have to modify everything according to the situation. You are treating a patient with all the dimensions, not from the perspective of the tumor surgeon or from the deformity surgeon or something, or the limb reconstruction surgeon alone.
I see, Professor Gamal, you don't use guidelines. I think you have your own guidelines according to the patient condition.
I don't have guidelines, actually.
Yes.
Thank you, Mohammed, for exaggerating this point. The problem is, I said that before, especially in the West. You know, when they talk, they give guidelines or something.
Yeah.
When they talk about lengthening, one of the guys they talk about, if you see his website, he speaks about that he has the greatest experience in bone lengthening on earth. But you look to his cases, he's doing 300 lengthening nails per year or something. But I want to show you that the resident in Mansoura University can do 500 lengthening nails per year. Lengthening nails are just like interlocking nails. So why you are the greatest? And even if you do lengthening in normal patients, do you call this an experience? You know, deformities in our area and bone infection or something like this is like influenza in the West.
Yeah.
Why do people exaggerate their experience? Exaggerate their experience, that means if you look to the lengthening, If you look to the papers of lengthening, and I presented that before in my paper in 2020 about the experience in lengthening. And they have a paper about 33 patients, and the period was done over about 15 years. And it's coming from 5 centers, and they call it multi-centric study. And every center has, on the average, 5 surgeons. So the experience of each surgeon is something like 0.1 patient per year. But they talk about the guidelines and the experience. And this is very funny. So when we talk about limb reconstruction and lengthening, you have to think about the surgeon load. Why on earth, when we talk about arthroplasty, when we talk about knee arthroplasty and hip arthroplasty, you talk about the surgeon load and the hospital load. How many patients they do per year? If you do 50 total knees per year, you are a casual surgeon. You cannot speak about opinions or something like this. So why on earth, if you do a 0.1 patient per year lengthening, they talk about the guidelines of lengthening? It's a bit strange for me.
Thank you so much, Professor Gamal. I don't see any questions. Professor Gamal, would you please stop sharing screen, sir?
Right.
Thank you, sir.